guidelines that we currently have relate to how to lower cardiovascular risk factors. So this isn't really a risk factor in a sense, more of a risk indicator. There is some data suggesting that these calcifications may be modifiable in the sense that if they are there, they may be able to show regression. That's an area that I think needs more research. I don't think this changes our recommendations in terms of what patients should be doing for their cardiovascular health. You know, still certainly exercise and diet and blood pressure control and control of diabetes and hypercholesterolemia and smoking cessation. All those things should continue. But I guess the question will be, if a patient has these calcifications, will it tip the scales in terms of 5 or 10 year prediction of cardiovascular disease, and then increase the aggressiveness, so to speak? In other words, in current algorithms, patients with heart disease or a heart disease equivalent would have more aggressive hypercholesterolemia treatment and so forth. So, where does this fit in terms of our predictability of future cardiovascular risk?
Do you have any ideas?
No, not yet. That's where we need to go. Right, so in our research, we controlled for age and still showed an association. There was still, after controlling for age, stroke and diabetes was still significantly more prevalent in BAC positive patients. And in the prospective study, even when controlling for age, those with BAC had a higher likelihood of developing coronary disease. So it does still seem to be a phenomenon even after controlling for age. In our 5-year data, we did an age-matched control group and still saw a significant difference. Yeah, great question. So I had the opportunity the other night at the presidential address to thank the organization for a wonderful year and to review some of the presidential initiatives. One of them obviously has been to continue our strong mission of educating our patients and women and helping bring the best care we can to menopausal women. Also, we've been working very hard on what we consider reopening the conversation in a sense of the use and utilization of hormonal therapy. Years ago, when the WHI first came out, there was a phrase that began to be used commonly saying that we should give the lowest dose for the shortest duration. And the intention of that phraseology was very well-meaning, but it really ended up getting misused in a sense, or misinterpreted, I guess is a better way to put it, and almost has a medical legal flair to it, and in many cases causes women to be fearful of hormones, thinking that they need to get off of it as quickly as they can and be on the lowest dose for safety reasons. Well, the real question is, shouldn't we be talking about what's the appropriate dose via the appropriate route for the appropriate duration? And so one of the initiatives or ways of meeting that initiative was through a survey that we're doing to the NAMS membership, and we're looking at some of the challenging cases and how people would utilize hormonal therapy in some of the difficult cases. And the other was through our third UDN Translational Science Symposium, which was on Tuesday, and had all the experts in our organization and in the field helping look at that exact topic of dose, route of administration, duration of use, extended use, and beginning to address that topic through that venue. We've also been working on continuing to bring menopause education to all of our learners, and that's been accomplished through the NAMS Pfizer Education Award. That we have many residents and DMP students and fellows that are here as part of that program. And the other is through a clinical mentorship program where we're going to be pairing mentors and mentees for people that want to start menopause clinics in their institution. So it's very exciting.